Hello, everyone, and welcome to NDARC's weekly webinar. My name is Tom Santo Jr., and I'm a postdoc at NDARC, and I'm thrilled to be hosting today's session where we'll be exploring critical insights into the prevalence of mental illness and substance use disorders among justice-involved populations. Before we begin, I'd like to acknowledge the Gadigal people, who are the traditional owners of the land on which I'm presenting today and where NDARC is situated. I'd also like to acknowledge the traditional owners of the country and throughout Australia, recognizing that our speakers and the audience will join us from various locations across Australia and globally, and would also like to pay my respects to elders past and present and extend that respect to any First Nations people here today. So it's my pleasure to introduce today's presenter, Dr. Darcy Coulter. Dr. Coulter is a research fellow at the Justice Health Group at the Population School of Public Health at Curtin University, and his research is deeply rooted in understanding and improving health and justice outcomes among marginalized populations. Throughout his PhD and subsequent research roles, he has gained experience with both survey and administrative health data, linking individual level surveys to and assessments to administrative linked data, which makes him uniquely qualified to talk about today's topic. It's also my pleasure to host Professor Stuart Kinner as a panelist for today's Q&A session at the end. Professor Kinner is a leading expert in health equity at Curtin University and heads the Justice Health Group there, which spans both Curtin University and Murdoch Children's Research Institute. He's had over 300 publications with significant contributions to national and international advisory groups regarding justice health, and his research profoundly impacts our understanding of the health services and outcomes for people who are in contact with the criminal justice system. Today, Dr. Coulter will be presenting on the use of multiple data sources to ascertain mental illness, substance use disorder, and dual diagnosis among people who are in custody. And in this webinar, he'll share prevalence rates of estimates of mental illness, substance use disorders among both non-Indigenous and Aboriginal and Torres Strait Islander people in custody. And it's now my pleasure to introduce Darcy Coulter. And please turn on your mic and camera whenever you're ready and get started. Look forward to your presentation.
Oh, thanks, Tom. And thanks for having me here today. I'd just like to also start by acknowledging the traditional custodians of the lands on which we're all located today. For me, that's the Wurundjeri people of the Kulin Nation. And I want to pay my respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander people here today. And importantly, to those who participated in the current study. So the study I'm going to be talking about today, I've been conducting with my colleagues listed here, and it is a bit of a work in progress. So any comments you have at the end that you think will improve the study, I'm very open to hearing. But really at its core, we're looking at using different sources of data to ascertain prevalence estimates for mental illness, substance use disorder, and their co-occurrence for people in custody. So a bit of an aim and overview of what we did. We had a sample of non-Indigenous people and Aboriginal and Torres Strait Islander people in prison. And we had 3 different sources of data that contained diagnoses. So we had some survey responses, we had prison medical records, and we had some inpatient and emergency department data. So we wanted to assess the concordance between these 3 sources of data to see the overlap of diagnoses, specifically in terms of mental illness, substance use disorder, and dual diagnosis, so that co-occurrence of mental illness and substance use disorder. And then we wanted to look at the effect of prevalence estimates when we start using multiple sources of data compared to individual data sources. So I want to be clear from the outset that the study wasn't designed to necessarily produce estimates that were in line with true prevalence. Its main purpose was really to demonstrate the variability of known diagnoses between the data sources. So we weren't trying to uncover previously undiagnosed conditions. And because of this, and also to adhere to some data sovereignty principles, we weren't attempting to compare the prevalence estimates of the non-Indigenous sample and the Aboriginal and Torres Strait Islander sample. So a bit of background about, I guess, why we're conducting this study and some questions that I think are important to answer. So first of all, why are we looking at people in custody? We know that people in custody have disproportionately high rates of both mental illness and substance use disorders. So people leaving prison have far higher rates of primary and acute health service use after release from prison compared to the general community. They're at greatly increased risk of death in the period after release. And we know that both mental illness and substance use are prominent factors in this risk of post-release death. People in prison are frequently underdiagnosed and undertreated, and prisons also provide a unique opportunity to identify someone's health needs and to treat them. Why are we looking at dual diagnosis? So dual diagnosis, which we're defining as, both a mental illness diagnosis and a substance use disorder diagnosis. We know that people with a dual diagnosis, they're a unique cohort from those with the individual diagnoses. So they've got different criminal health backgrounds and trajectories. So among people exposed to the criminal justice system, those with dual diagnoses have more extensive criminal histories. They're more frequent and serious offending, greater segregation within prison, longer hospitalizations. They're also a growing cohort. So a few studies have come out recently from Canada and Scandinavia, looking at the decade starting from 2010 onwards. And the people entering prison with a dual diagnosis has grown throughout those years, both in terms of raw numbers and as a proportion of the entire prison population. And they have unique health needs. So when you've got multiple co-occurring health problems, they interact and they increase the complexity of the management and treatment of those conditions, and any increase in the complexity of management will likely result in poorer health and justice outcomes. And I should also say that, and we know that because they're co-occurring conditions, integrated treatments probably of benefit, but we know that often mental health services and AOD services work in isolation. And then finally, why are we looking at prevalence estimates? So accurate and reliable prevalence estimates are really the most basic information we need to identify health needs, appropriately allocate resources, inform health service delivery, both in prisons and in community, so there's transitional health services, and inform their any release planning as well. So a bit about what's currently being done. I'm not going to go through everything that's out there in terms of prevalence estimates for mental health and substance use disorder diagnoses among people in prisons in Australia. But some of the notable examples, the AIHW puts out a report approximately every 2 to 3 years, and they have done since 2009. It's the most routinely and publicly reported measure of health of Australia's prisoners. And the part that's relevant for this current study, it's a survey, asks people in prisons if they've ever had a mental health or behavioural condition, including drug and alcohol abuse. Have they ever been told they have one by a doctor, psychiatrist, psychologist, or nurse? One of the issues with this is that by including that drug and alcohol abuse within the one question, we can't really tease out dual diagnosis, and we can't tease out substance use disorders by themselves. The other the other limitation of these reports, and they present proportions like this. The other limitation of these reports are that they're a very small sample. So this is looking at prison entrants. In the 2022 report, they had 371 entrants, whereas we know we have 40,000 people in Australian prisons. So it's a very small sample. Some states will choose not to participate. The AIHW, readily, they're very transparent. They know that it's not a representative sample. It's a good snapshot, but it's a convenient sample. So as they report there, they really are just proportions of their data collection, not prevalence estimates. The ABS has had a few national studies of mental health and wellbeing. The latest one was in 2020 and 2022. They use some diagnostic screeners to report people's mental health conditions, including substance use disorders. So they separate that out, unlike the AIHW does. And they also present it with people who have ever been incarcerated or have not been incarcerated, which is good to know. But really, because we don't know when these incarcerations happened, they don't inform current prison health service need or current transitional health service need. So some of these people may have been incarcerated 3 decades ago, some may have been incarcerated 6 months ago. That information isn't available. And then on an ad hoc basis, you've got academic papers and reports that come out. This is not an exhaustive list, but I just wanted to show some of the different methods that people use. So Tony Butler and colleagues use diagnostic interviews going into New South Wales prisons. Brown and colleagues use some self-report measures, so surveys that have been conducted in New South Wales over 3 different time periods. And Stewart and colleagues up in Queensland use some inpatient hospital administrative data. The main thing I want to stress here is that most of what's out there really uses one source of data. And that's a bit of a problem, because we know that each source of data, whether it's self-reports, whether it's administrative data, whether it's diagnostic interviews, really has their own limitations and advantages. So I don't want to spend a huge amount of time on this slide, because I'm sure a lot of people are aware of the limitations of surveys, the advantages of administrative data. But, so surveys are obviously costly. It's hard to cover the whole population, not very feasible often. Administrative data, on the other hand, relatively easy to collect, but then you're limited in terms of what data you have, the time period, the source of the diagnosis, where the diagnosis happened as well. So I'll just leave that up for a sec. But yeah, it's just important to note that each source of data has its own limitations and advantages. What we used in the current study, we used data from the Health After Release from Prison study. And I think both Stuart Kinner and Craig Cumming have presented some work in previous webinars here that have also used data from the HARP study. What it was some face-to-face interviews conducted with people in the 6 weeks prior to their release from prisons. These interviews were focused on their health, and from Queensland and WA prisons. Ended up with about 2,700 participants. And then that survey data was linked with their in-prison medical records from that particular incarceration period, and also with various other corrections and health administrative data sets. The Queensland study, the Queensland arm of the study ran from 2008 to 2010. So that's when the baseline surveys happened. And the Western Australian study was 2013 to 2016. In our current study, we constructed our diagnoses. So they were exclusive measures of mental illness only, substance use disorder only, and dual diagnosis. And I want to stress that they were exclusive measures because it really affects the interpretation of some of our results. And so by exclusive, I mean if someone's coded as having a mental illness diagnosis and a substance use disorder diagnosis, we're only coding them as having a dual diagnosis. Our baseline survey asked people a very similar question to what the AIHW reports ask. Have you ever been told by a doctor, psychologist or psychiatrist that you have a mental illness? And then we asked, if yes, what type? And that's where we were able to tease out the substance use disorder, substance use disorder diagnosis. Prison medical records, we use the ICPC codes, so the primary care classification codes. And our administrative data in this study was inpatient and emergency department data using ICD-10 codes. This is just a bit of a diagram to sort of get your head around what time periods our data covered, potentially covered. I've got here that the baseline survey covers from birth to incarceration, because theoretically we're asking if you've ever received a diagnosis. Obviously in practice that's probably not actually going to cover from birth onwards, but there's the potential diagnosis coverage. Our administrative data covers their index incarceration and the years leading up to that incarceration. The number of years differs depending on the state they were in, which data set we're using, inpatient or emergency department, and really when they were incarcerated as well. And our prison medical records adjust for that index incarceration, so that incarceration period where they completed the baseline interview. We ended up with just under 1,700 non-Indigenous participants and just under 1,000 Aboriginal and Torres Strait Islander participants, mostly male, and the non-Indigenous participants were slightly older than the Aboriginal and Torres Strait Islander participants. Our analyses, so we conducted some prevalence estimates, which really at their core are just the proportion of the sample with the diagnosis. Our sample wasn't necessarily representative of the entire prison population. So for example, women were deliberately oversampled to allow for some sex stratified analyses, which we didn't conduct in this study, but other studies using the data have used. So we stratified by the state, clustered by the prison, and then we weighted the sample, based on national prisoner population statistics. So things like age, sex, the proportion of sentenced prisoners, proportion of non-Indigenous and Aboriginal and Torres Strait Islander prisoners. And we present some bias-corrected bootstrapped estimates. We also looked at the agreement or the concordance at the individual level of diagnoses. So we looked at the overlap of diagnoses across the data sources. And then we also present some inter-rater reliability coefficients. And we ran all our analyses separately for the two samples. So I'll get straight into some results. Just to quickly explain the graph, just to get your head around it, we've got each individual data source down here, and then we start to compare start to combine data sources here. Really, I'm just going to focus on all data sources combined compared to the individual data sets. So you can see here self-report, and this is mental illness only that we're reporting. So for mental illness only, the non-Indigenous sample is self-reporting 35%, 22% for the Aboriginal and Torres Strait Islander sample. And then this drops down when we start looking at the other data sources and the combined data sources. Again, just remember that they're exclusive measures, so it may seem weird that they're dropping down when we start combining data sources, but that's going to happen if someone is self-reporting mental illness only, but our other data sources identify a substance use disorder. So dual diagnosis is going to go up, but mental illness only would go down in that scenario. Looking at substance use disorder only, self-reports of substance use disorder only were quite low. Prevalence estimates were both under 5% for both samples. And this increased among the individual data sets and also the combined data sets. So looking at all data sources, we're up at about 15% for the non-Indigenous sample and 27% for the Aboriginal and Torres Strait Islander sample. And then dual diagnosis, huge change from self-reports of dual diagnosis to all data sources combined. So self-reports of dual diagnosis were both under 10% for the two samples, and then they're both above 40% for the combined data sources, which is quite a large jump. These numbers here are really just what I presented before in the graphs, but I sort of wanted to show where the significant differences are actually seen. So in terms of surveys compared to all data sources combined, every diagnosis for both samples was significantly different to the combined data sources. So we see more self-reports of no diagnosis and mental illness only, and we see much lower self-reports of substance use disorder and dual diagnosis. So much lower self-reports of the two diagnoses that involve substance use, and that's consistent across the two samples. When we look at prison medical records and compare them to all the data sources, we see higher estimates of no diagnosis and lower estimates of dual diagnosis. Not really surprising, given the limited time frame that the prison medical records cover. And we also see some higher estimates of substance use disorder in the non-Indigenous sample. And then with our linked administrative data, our hospital data, we again see higher rates of no diagnosis, lower rates of dual diagnosis. Again, they cover a smaller time period than the surveys theoretically do. So it's not that unexpected. We do also see lower rates of mental illness only in the non-Indigenous sample. We then wanted to look at where the overlap was in the diagnoses. So, the prevalence estimates tell us how they change across the data sources and when we start combining data sources, but we don't actually see, the consistency at the individual level across the data sources. So, for example, we have 63 people self-reporting that they have a substance use disorder only in the non-Indigenous sample here. And 230, and we identified 233 people in the hospital and the inpatient and emergency department data. But these prevalence estimates don't really tell us how many of those 63 people are seen in the 233. So we produced these diagrams here, and I'm going to zoom in because I think they may be quite small. So just as a quick explanation of what these represent, to get your head around them, we've got the diagnosis at the top. So here we've got no diagnosis and mental illness only, and they really represent everybody with that diagnosis, or everyone with no diagnosis in this case. So the percentages here will all add up to 100. And the raw numbers here for the non-overlapping circles we've actually seen before in the previous tables, but these overlapping raw numbers are new information. Really what I want to point out is that when we start looking at all data sources combined, so this middle sort of triangular shape, the overlap is quite low. So 9% for no diagnosis, ranging up to around 22% for dual diagnosis. The other, I guess, interesting thing to note is the very small, so survey data seems to overlap a lot with other data sources for both substance use disorder and dual diagnosis. So it suggests that when people do self-report a substance use disorder, that's generally backed up by our other data sources. And we sort of see the opposite when looking at both no diagnosis and mental illness only. My interpretation of this result is that people may be underreporting their substance use disorders. So when we identify a substance use disorder in our other data sets, that's when no diagnosis and mental illness only look like those self-reports are not being backed up by the other data sources. That was the non-Indigenous sample. We also ran the Aboriginal and Torres Strait Islander sample, but really the results are very similar. It's got very low levels of overlap across all data sources, ranging up to 22% again for dual diagnosis. And then we see the same thing with the overlap of self-reports for substance use disorders, dual diagnosis, and less overlap for the no diagnosis and mental illness only. So very similar results to the non-Indigenous sample. We then ran some more formal measures of agreement, so some inter-rater reliability coefficients, presented the percentage agreement, Cohen's kappa, and a prevalence and bias adjusted kappa here. Really, we're not going to focus on Cohen's kappa. Running these analyses spat out some weird results. So you can see here, substance use disorder only has a very low value, even though the, here, it's a very low value, even though the percentage agreement is actually quite high. So that's an issue with Cohen's kappa around prevalence estimates that aren't close to 50%, which is why we present the prevalence and bias adjusted kappa using some common interpretation metrics. Most of our diagnoses across the data sources seem to agree to a moderate degree, apart from substance use disorder only for the Aboriginal and Torres Strait Islander sample, which is just here at the high end of fair agreement. Just going to summarize results now. Really, as you would have seen, prevalence estimates vary greatly depending on the data source we use. Specifically, when we're comparing all the data sources combined to self-reports, we see substantial increases in both substance use disorder diagnoses only and dual diagnosis prevalences, and decreases in no diagnosis and mental illness only. it's important to note here that, yes, disclosing a substance use disorder is, in essence, disclosing either past or current substance use, which brings with it, can bring with it stigma, shame, discrimination, and for this cohort in particular, who are about to be released from prison, real or anticipated consequences for their release for healthcare, housing, employment, child protection. Yeah. It's also, I mean, that's saying that there may be deliberate non-disclosures of substance use. Also, people may just not, their memory may not be great for some of these diagnoses. I mean, attending emergency departments, even if your diagnosis is communicated to you well, they don't facilitate great recall or retention of diagnoses. We saw moderate agreement between the data sources for most of our diagnoses, which is, I think, encouraging that, it gives us some confidence that maybe combining the data sources is the right way to go. We were never expecting perfect agreement. The data sources cover, have different timeframes. They cover different sources of diagnoses. So agreement was never expected to be perfect. And the patterns of results for both the changes in prevalence estimates and the agreement across the two samples was quite similar. So obviously the prevalence estimates differed a bit, but the actual change when we looked at individual data sources and combined the multiple data sources was quite consistent across the two samples. So the implications of this study are really that relying on any one source of data is, in terms of prevalence to ascertain prevalence estimates, is probably going to result in inaccurate prevalence estimates, particularly using self-reports for substance use disorders, dual diagnoses, are probably going to underestimate the true lifetime prevalence of these diagnoses. Even our estimates are most likely underestimating the true prevalence. So we're missing data from other jurisdictions, diagnoses that happened in the community that weren't at the emergency department or inpatient. Diagnoses from psychologists, GPs, psychiatrists in the community. So our estimates are most likely underestimating the true prevalence as well. And this has real implications for in-prison, transitional and community health service resources. So if we're already viewing these services as underfunded based on estimates that may be inaccurate, the level of underfunding may be worse than first thought. Some limitations to these studies. So we excluded people with severe mental illnesses from the interview stage and subsequently the rest of the study. So another reason why our estimates are most likely underestimates. Also, we were limited to 2 states. Again, our inpatient emergency department data represents acute or severe presentations, so we're missing those other diagnoses that happened, with a psychologist in the community, at an ATCHO, or other community mental health and AOD services. And we're also looking at quite Western conceptualizations of mental illness, substance use disorder, and dual diagnosis. So we're using, ICD codes, we're using primary care classification codes, which don't, fit into a social and emotional well-being model well. They're just one piece of the puzzle. They're not a very holistic view. So they may not be as relevant or meaningful to treatment services programs that are appropriate for the Aboriginal and Torres Strait Islander cohorts leaving prison. I'm going to leave it there. Happy to take some questions. Yeah, thank you.
Thank you so much, Darcy. And that was a really fantastic and interesting presentation. I think it's relevant to a lot of the work that we're doing at NDARC, and maybe me being a little bit biased, that myself is doing as well. Stuart, I wanted to invite you to turn your camera and microphone on, and also if you wanted to stop sharing, Darcy, that would be
Yeah, sure.
awesome. Cool. So now we have us all front and center. So first question I just had for you, Darcy, was just moving forward, looking at these different types of survey administrative data, the in-prison consultations, or not consultations, but data. What do you think moving forward might be the best kind of way for governments and other public policy planning things to use for kind of ascertaining substance use disorders and mental disorders?
Yeah, I mean, it's a tricky one. I think, administrative data is probably the way to go. It's not easy, but it's relatively easy to extract and analyze. You don't have the costs of, running a survey constantly, and doesn't have some of the bias. Well, there will be biases, but you won't have all the biases you see in self-reports. You won't have the issue of people deliberately non-disclosing substance use disorders. But I guess the real thing to be mindful of is, I mean, in our case, we only had inpatient and emergency department data. Any prevalence estimates using linked administrative data need to be more comprehensive. So they need to include like those community mental health services, Medicare. I know you don't get diagnoses with Medicare, but you at least can see when mental health assessments happened. So inpatient emergency department data is obviously just a very severe and acute presentation. And so using linked data, it needs to be more comprehensive than that. Yeah, I don't know. I'm sure Stuart has some thoughts on the best way for governments to look at prevalence estimates.
Darcy, I think the short version, based on your fantastic presentation, that would be that we need more than one data source. Yeah, I mean, you make the great point though that administrative data are not perfect, but more comprehensive is better than less comprehensive.
Yeah.
No, absolutely. And it's still so interesting to see, I guess, this. So people, maybe I should clarify something first. As far as so when we saw the 3%, for example, for the substance use disorders for people reporting in the survey, now that was in relation to whether or not they had been diagnosed, or whether or not they were like self-reporting that they thought they had one, just to clarify for myself.
The question was around if you've ever been told by a doctor or psychologist or on that you've had a diagnosis. Yeah.
Interesting to see how that may change if it was, whether or not the person's personal interpretation. But I mean, that's difficult to kind of go across what people would interpret as the substance use disorder themselves. And yeah, interesting. There was one question that we had from the start from Kylie in regards to what would be interesting to see if before and after COVID. I don't know if anyone had thoughts there.
Yeah, I mean, our data is obviously a long time before COVID. I'm not sure. I don't know how it would change across COVID. Yeah.
One thought would be, so we are in the process of updating and expanding that linkage to include data from New South Wales and Victoria as well. And in the process of that, the new data we have will span COVID. So it's a question that we can ask with the data. I mean, I guess it's conceivable that both prison medical services and hospital services would have had a higher threshold for engagement during the peak of COVID, and that might result in lower ascertainment of conditions during that period. maybe there are more mental health issues during COVID, particularly for people who are incarcerated and may have been even more restricted in their activities. It's a great question. It's an empirical question and one that we can definitely look at in the next 12 to 18 months.
Great points there. I would say we'll get to another one about sorry, there's just there's so many great questions. It's flying through my screen. In regards to nurse-led models in prison impacting on diagnosis rates, I'm not sure what the situation is with where the data was collected from, and whether or not there are nurse-led models. And the Penny also mentioned that we often hear there are some reluctance to add to the problem list or diagnosis list, maybe of what they're already assessing for.
Yeah.
If there was any thoughts there?
Yeah, I'm not sure about the nurse-led models. I don't think our question specifically mentioned a nurse, but I have seen, I think the AIHW may ask about, like specifically mentions, has a nurse told you that you have a mental health condition or behavioral condition? I think maybe it goes back to also what you said, Tom. I don't know how people actually interpret that question. I don't know if, you know, a nurse had told them that they have a mental illness, if they'd decide not to answer yes to that question just because it was a nurse and wasn't a doctor or psychologist or psychiatrist. So yeah, I'm not sure how the nurse-led models would impact prevalence estimates in our regard. Stuart looks like he has his hand up to answer.
Yeah, I wonder if the question might be asking about the fact that nurses may be less likely to be diagnosing. They're just sort of providing emergent primary care. So in that regard, the thing I'd say, our prison medical records, what we did is we got very determined research assistants to go in and access what were then paper medical records, and they coded every encounter with the Prison Health Service during that index episode of incarceration, whether that was 3 months or 30 years. And then each encounter was coded using a thing called the ICPC2, which is the International Classification of Primary Care. And it's the presenting complaint and diagnosis codes that are part of that coding process in the ICPC2 that we used. So as Darcy said, it was ICD-10 9 and 10 codes for the administrative data, but it was ICPC2 codes for the prison medical record. So in other words, you didn't need to have a nurse formally diagnosing somebody. What would happen would be we would code those prison medical records using the ICPC2, and it, you know, and that may have been a nurse encounter that led to a psychiatrist coming in or a GP, you know, making a formal diagnosis, or it may not.
This kind of relates to a question from Josephine about whether or not people are always told what the clinician thinks the diagnosis actually is. So maybe that would capture a little bit more of what a person's necessarily told and then answered within the questions that you were talking about in the survey, Darcy. It may capture more than that.
Yeah, I mean, conducting this study, I had that thought around, especially the emergency department data. You know, I've been in at the emergency department and I don't recall actually being told what the diagnosis was. You know why you're in there. So actually recalling that and recalling it when you're in the interview. Also, if you're in there for a substance use related issue in the emergency department, it's, you know, probably quite severe and acute. I can't imagine many people would remember their specific diagnosis when they're in there. There's also a lot of work around, like a lot of research out there that diagnoses are often not recalled well, like immediately after leaving emergency departments. And one of the issues is also that they're just not communicated well. So yeah, it's also that.
No, absolutely. It reminds me of a survey that we did, and then also my own personal experience, but a survey where we're looking at people who are receiving methadone or buprenorphine for opioid dependence, and then actually asking people whether or not they've, you know, received a diagnosis of opioid dependence before, and so far lower than the number of people who are actually receiving a medication for opioid dependence far lower people actually have said, I've received a diagnosis
Yeah.
for that, but that's a kind of a qualifier for getting the medication. But the communication there, as you said, and what people understand and interpret as a diagnosis is can change person to person.
Yeah.
And again, Kylie kind of speaking to that, saying about how mental health professionals sometimes diagnose without telling clients, so I guess directly. And Amber had a question about how much were urine drug screen findings involved at all in contribution to the ED data or prison record data? No? Okay, cool. And we have some other points were about after release from incarceration and self-reporting, if I mean, obviously, I don't think your data set had that, but whether or not that would change afterwards. And just my initial thoughts from that would be, it would be interesting to see how much prison and being incarcerated itself could have to do with someone's mental health. As far as the prison records potentially would go. I mean, obviously that wouldn't affect the encounters with the ED and other places before they were incarcerated, but yeah, I don't know if there's any thoughts there, talking about how self-reporting after release would be helpful, and then also, I guess, access to substances after release, I guess, as well. And we know that that's a critical period.
Yeah, I mean, so we actually do have data following release. The reason this study just focused on prior to release was because it was all about known diagnoses. So we wanted to look at when the person was interviewed and they, said whether they had a diagnosis or not, whether that lined up with their linked data from previous. I mean, Stuart can probably speak more to this, but I think there were a couple of follow-up surveys done in the community as well, which we didn't use in this study. But yeah, that could also be linked with the administrative data afterwards as well.
Yeah, and just to add to that, I think, in terms of why what you're doing is really important, just showing that no one data source can give us a reasonable estimate of prevalence is important, but it's got a lot of other implications as well. And for me, a really important one is that it really points to the problems we have with continuity of health and medical information for people who experience incarceration in Australia. Now, my understanding is that's still the case even in jurisdictions like New South Wales, where at least it's the Department of Health that's delivering healthcare in prisons. It's still a separate EMR, medical record.
Yep.
In Queensland, that was the case as well. It's Department of Health delivering healthcare, but with a separate EMR in prison. In WA, it's the Department of Justice delivering healthcare. And the point here is we want to optimize our ascertainment of both current conditions and medical history and risk of future health-related conditions. And the nearest thing to low-hanging fruit seems to be to have continuity of health and medical information. And we're just staggeringly far off that. And I think, to me, Darcy, one of the really important messages from your work is that has really meaningful consequences both for research and for service planning, and for providing appropriate care for people.
Mm. Yeah. I mean, that was one of the things I struggled with here. I was like, how is the funding for these services? What's it based on? Because I don't know where, what estimates are they basing them on, if they are, because they're all over the place, and they're most likely inaccurate.
Well, shout out to the Productivity Commission, who since 2017 have excluded prison healthcare costs from the Corrective Services chapter. So although we used to have some vague idea of that, we now have none.
Right. Mm. Kind of linking to that, Craig had a question, or saying rather than COVID, data completeness could be affected by the PBS S100 changes and the use of Medicare numbers in custody, or I guess lack thereof, in some cases. Was there any thoughts on that? I know that would certainly have some changes in regards to opioid dependence treatment with the recent changes there.
I'm not on top of the changes, so I might let Stuart, take this.
Yeah, look, the change, the S100 change with respect to opioid agonist treatment came in after this study, so that wouldn't be relevant. Yeah. It would be relevant if we were including, for example, PBS data in the work that we're doing. I think Darcy was
Right.
alluding to the fact that in an ideal world, we'd used, ambulatory mental health and AOD records, PBS records, Medicare records. Maybe that's the next study, Darcy, is to kind of expand it out. PBS data would be potentially increasing ascertainment now because we'll be able to pick up people on opioid agonist treatment, except of course that if they're in prison and excluded from the PBS, that wouldn't be picked up at all unless an arrangement is made like with direct acting antivirals.
Yeah.
So it remains to be seen how that's going to play out in prisons.
Yeah. No, absolutely. Well, I guess remains to be seen. Another quick question from Yingben, and we might end it after this, but wondering if there were plans with the survey results, prevalence characteristics, and patterns to create a prediction model, and maybe how generally, I guess, you intend to use some of the data in the future. If there was any plans around these things to find out more questions, you can kind of expand on that in relation to the data set as a whole, if you'd like, or yes.
I'm not sure. I mean, what the question was related to in terms of what we're trying to predict.
Yeah.
But we are, one of the next steps in this project is to look at the link between mental illness, substance use disorders, dual diagnosis, and reincarceration. But yeah, I guess it depends what we're looking at as our outcome for prediction there.
I think, this is kind of one of those lay the groundwork important papers for what's going to be like a program of research for us. Dual diagnosis is a really important marker for a bunch of really significant outcomes. Bahaili Pawult, who's joined us from Ethiopia doing his PhD with us now, I know he's on the call, is looking at the co-occurrence of dual diagnosis with chronic disease, which is, a really big issue, particularly given the issues of diagnostic overshadowing. So I think Darcy's kind of laying the groundwork for us to look at a whole bunch of outcomes, and we have the capacity to do that with the data we have.
And I suppose we'll do one more, and I think it relates to the importance of stigma that people were talking, or that Darcy, you were speaking about before. But they were asking, or Kylie was asking about the surveys being taken from only participants in low classification correctional facilities, if that's correct. And Kylie was talking about the fear of repercussion and punitive effects. Even if that wasn't the case, I do think it's definitely important to point that out in regards to, even if it may or may not have affected the survey answers, but I'll get your opinion there. But it's certainly something that we need to address and discuss about how substance use disorders are treated differently, and will have potential repercussions for people if they disclose them in or after incarceration, as we know, in the community as well.
That's what I was getting at a little bit towards the end. Obviously we don't know for sure in this study why, or why people, the disclosure, they may not be disclosing substance use, but yeah, obviously there's the potential for real repercussions for them. I know some research I was reading the other day, I think was talking about a needle exchange program in some Canadian prisons where everyone was like, yeah, it's great until you actually access it, and then all the correctional officers start targeting you because they know that you inject substances. I wouldn't be surprised if some of the responses were tempered based on what they thought the repercussions may have been. I wasn't actually part of this project when the surveys happened, so Stuart might have some more thoughts on that.
Yeah, so it certainly wasn't minimum security prisons only. In fact, we made a great effort to approximate a representative sample, with the exception of oversampling women, which is really important because there's just tons of studies that recruit people who are known to have mental illness and then can't estimate the prevalence of mental illness, recruit people with an opioid use disorder and therefore can't estimate the prevalence of that. So there's a surprisingly small minority of the literature out there that can give us anything even approximating a prevalence estimate, because there's a whole lot of untested assumptions underpinning the recruitment and sampling frameworks.
Well, thank you for all your hard work in this area, Stuart and Darcy, and And we as a whole thank you for coming to speak again in regards to prison health, and wish you the best of luck with all the work, and look forward to continuing to talk about this work and as a whole. Thank you.
Yeah, thanks so much for having me.
Awesome.